I think we'll start. In the meantime, we'll get your presentation and play it from here. So good morning, everyone. Uh, um, since Dr. Punjani has joined us for the first time, I'll give him a brief introduction about this online education portal, which we have named Jaipur Surgical Festival. We borrowed the name from the very popular and famous Jaipur Literature Festival. And this we started about 2.5 years ago when I moved from Lucknow to Jaipur. And my colleague, Dr. Anand Nagar, who is an associate professor in HPV surgery and liver transplant, he has been looking after this portal for the last 2.5 years. We conduct a session every Saturday morning, like today, 9 to 10, where students, mainly who are pursuing their MCH or DNB in GI or HPV surgery, but some students who are doing general surgery also join, and we have some faculty members, and Dr. Rajen Desai from Hyderabad has been a regular faculty member who joins us to conduct these sessions. Usually students present cases, sometimes they present operative procedures, and the faculty moderates. Very recently, we started a series of master classes also. We've already done 2. So these are done on last Thursday and Friday of the month, 7 to 9 p.m. online. And we cover a single theme. So first master class was living donor liver transplant. Second was on safe cholecystectomy. And the third one, which is scheduled for this month, will be on chronic pancreatitis. We will be soon making the announcement. So Dr. Anand probably heard you in some conference about your consent process. So he asked me that whether we can invite you. So I'm thankful to you that you've accepted our invitation. But before I give the podium to you, I thought I'll just make a brief introductory presentation about what are the medical legal issues involved in laparoscopic cholecystectomy. Some of these issues are applicable to any procedure in general, but they are specific for laparoscopic cholecystectomy. So cholecystectomy, after it changed from open to lap, suddenly the number of, not only the number of cholecystectomies has increased, but number of litigations also has increased. So in the US, in the open chole era, over 20 years, there were only 68 litigation cases. But after that, there has been a spurt. And same way, there is data from the UK that anywhere between 4 to 7 out of 10,000 cholecystectomies which are performed will result in a litigation. Unfortunately or fortunately, there is not much Indian literature on medical legal issues of lap chole. So this is all the data which is primarily from US, UK and Netherlands. But suppose there is a case against one of us in the consumer forum, the judges or the members, the lawyers and the opposite party will produce this evidence. So it is important that we all also know about this evidence. Now, the cause of litigation in lap chole, in all these publications, the commonest cause, as is obvious, is bile duct injury, ranging from 40% to almost 80%. That means 40 to 80% of litigations which are related to cholecystectomy, the cause was bile duct injury, bowel, vascular injury, and other complications being the other causes. Now, patients with bile duct injury, when we take that as denominator, who filed a suit, ranges again from a low of 22% in Netherlands and 33% in UK to a very high of 71% in the US. So in the US, every 2 out of 3 patients who had a bile duct injury filed a medical legal suit. That is because US in general is a very litigious society, and lawyers kind of go after the patients and ask them to file a case against the hospital or the surgeon. Now, the situations where a case is filed include when the patient is young, there is an associated vascular injury, CVD transaction, complete injury rather than a minor injury, injury which is missed during the operation and detected or suspected in the post-op, delay for whatever reasons in the diagnosis, and late transfer to a higher center from the center where the injury occurred, and very importantly, repair by the injuring surgeon in the injuring hospital has been found to be a factor associated with litigation. Now, the prevalence. So, when a survey was done in the Association of Upper GI Surgeons in the UK, almost 1 out of 5 surgeons reported a medico-legal experience. Fortunately, in our country, the incidence is still low. A survey which we conducted when I was at SGPGI, we found that only 6% of 200 surgeons who responded said that they have had a medical legal case so far. And in fact, a review article once mentioned that if you want to completely avoid litigation, you should probably never do lab chole. Claim was awarded depending on which country you are. So in the UK, the claim rate is high, whereas in the Netherlands, the claim rate is the lowest. So it depends on the legal process of the country that how many of the cases which are filed, a claim is awarded. And when these claims were analyzed, the positive claims, the awarded claims, it was found that complete transaction, again, repair by the injuring surgeon in the injuring hospital, delay in referral, and a CBD injury as opposed to a cystic duct or a minor duct injury. These were factors which predicted that a claim will be awarded to the patient against the surgeon. And the amount of compensation, again, depends on the country. In the US, it could range from a mean of 200 to 700,000 US dollars, whereas it was less in countries like Italy and Netherlands. The amount of compensation also relates to delay in imaging, delayed diagnosis, need for re-laparotomy, and once again, repair in the injuring center, and obviously, if the patient has died.
Medical legal aspects of lab polycystic.
When it was investigated that what information is given to the patient or the relatives once an injury occurs, it was found that across countries, the information given to the patient or the information mentioned in the consent form was incomplete. And the patients were not either informed before the operation or after the injury occurred. And one publication suggested that there should be a procedure-specific consent form which should be nationally standardized, and it should list all common and all major complications. And that is what the effort is, that we hope to work with Dr. Punjani to devise a nationally accepted, which can be endorsed by the national societies of minimal invasive surgery, consent form for lap chole, so that there is no variation between surgeon A and surgeon B. Now, when consent forms were analyzed or surgeons were asked as to what you tell the patient, 200 surgeons were interviewed and 9 complications were kind of asked for. Only 3 out of these 9 complications were mentioned more than 50% of the time by these 200 surgeons. And bile duct injury was never mentioned by 25% and rarely mentioned by 22% of the surgeons who responded to the survey. So that is what the status of the consent and counseling form is. Now, if an injury occurs and if a case is filed against you, how you can defend yourself, these are the tips. If you have received proper structured training in minimal invasive surgery, if you took a good, detailed, written informed consent, which I'm sure Dr. Punjani is going to tell us about, if you always keep a high index of suspicion of bile duct injury and have a low threshold for investigation, at least liver function tests and ultrasound, if there is something wrong, provide complete information to the patient and relatives, do appropriate management in your hospital if it is possible, and if not, refer the patient to a proper biliary center for in time with a detailed referral note and proper documentation, and preferably talking to the surgeon or the gastroenterologist to whom you are referring the patient. Now, poor communication is another cause of litigation, and in one study, residents, surgical residents were asked to communicate a hypothetical situation of a bile duct injury and a hypothetical situation of an incidental gallbladder cancer finding to the relatives. And it was found that their communication for bile duct injury occurrence was very, very poor. They were hesitant, they were scared, and they could not communicate it properly. And it has been found that most claims are because of poor documentation. The case is filed because you did not communicate properly, and the case is decided against you because you did not document the case properly. So whether bile duct injury is a complication or an adverse event of a procedure, surgical procedure, or whether, on the other hand, it is a mishap, error, mistake, or even negligence is the big question. When experts were interviewed, they were given 10 cases of in which litigation was filed, in only one case, all 10 experts agreed. And in only 7 cases, half of them agreed. So that is the problem. And again, similarly, in Netherlands, it has happened that the accepted claim rate has fallen from 50% to 18%. And in Germany, in general, it has been observed that while earlier a bile duct injury was considered to be below the expected standard of care, now more and more experts are saying that it is an inherent complication of the treatment, that is the laparoscopic cholecystectomy. So, in my opinion, whether bile duct injury is a intentional or a culpable polydococide, I have borrowed again that term from the legal term culpable homicide, which is an act which does result in a person's death, but the intent was not causing death, and therefore it is not held equivalent to murder. And same way, I feel that a CBD injury does cause morbidity. Sometimes it causes mortality also, but in all cases, it does not amount to negligence. So this is a review which I had done a couple of years ago in the Journal of Minimal Access Surgery. It is available free on the internet. Those who want to read more about medico-legal aspects of bile duct injury, you can go through it, or please send me a mail. I'll be happy to send you a soft copy. So that is a brief background. As I mentioned, that there is very little data. Maybe I have missed some publications on medico-legal aspects of bile duct injury in India. And therefore, we have to rely on whatever information is available from the Western literature. So with that brief background, I will now request Dr. Punjani, who is a very senior consultant GI and minimally invasive and robotic surgeon attached to several hospitals, including Fortis and Breach Candy in Mumbai. And he is also a member of the legal team of the Indian Association of Gastrointestinal Endosurgeons. And as I said, Anand was very fascinated after listening to your presentation in one of the meetings, and he made a special arrangement that we have you on the Jaipur surgical tutorial. Dr. Punjani, please.
Yeah. So thank you.
Anand, would you like to say something about Dr. Punjani before I request him to start? Anand is traveling, so I'm not sure whether he will be able to connect. Anand, yes.
Sir, welcome, sir. Welcome, sir. Sir, now, sir can share his screen, sir. I received a call from Akshita ma'am. He can share his screen now.
Acha.
Just try once.
He's trying. Apna stop. Dr. Punjani, you can try. Otherwise, we will play.
Yeah,
we have got
your just 1 minute. Just 1 minute.
Yes.
Are you getting now?
We see that. Yeah. Yes. Good. Very good.
Okay.
Thank you.
Yes,
Yeah.
So,
Please.
in fact, I'm sorry for that goof up that happened. In fact, what has happened is the latest, there was something got upgraded, and then this all settings have changed. So anyway, I'm going to talk on laparoscopic cholecystectomy. So before I say something, I must give you a disclosure that this consent is not only prepared by me, but it is by a team of people. Dr. Iswarmurthy, who is right now a president of IAGS, in fact, first time, he created a legal cell of IAGS when during the new committee, when the new committee was formed, and I was made a chairman, and with me there was Dr. Suresh Vasishtha, Dr. M.G. Bhatt, Dr. Suresh Deshpande. So all four of us, in fact, thought as Dr. Kapoor said, that this is a very common problem, that people are being sued for something that happens wrong in laparoscopic cholecystectomy. And in fact, Dr. Suresh Vasishtha went through it, and they found out that there are more than 1,200 cases that have happened in India today so far. So it's a huge number. Though in many of these cases, the surgeons have gone scot-free, but there are few who are even penalized. And the problem with all of them commonly was two things, as pointed out by Dr. Kapoor, is that one was the consent was not proper, and the second thing was documentation was not proper. So these are the two burning issues, and therefore, as an association, we thought we should do something to guide our all the members. And there was an attempt made to create this legal consent. So we had several Zoom meetings and several arguments, and at the end of a few months of preparations, we ultimately have prepared this consent. So though Dr. Iswarmurthy said that we will still not call it an IAGS consent, So that is still in a process where probably some seniors may make some changes. And in fact, I will request Dr. Kapoor to persuade the IAGS and let's come to have an Indian formatted proper consent where all of us write the same thing, and then we can face the court if the situation arises. So I actually bring a greetings from Mumbai. I can't change my slides. My slides are not changing. I think you only run.
Okay, so maybe we will play it from here.
Shall I stop then? Because it's not changing.
Sir,
Now,
you
we'll do it.
can do it again. Sir. Now you can see your slides. Maybe.
Yeah, but it's not changing.
Sir, please look at your desktop. You have opened two slides of this thing, probably.
Oh.
Stop share once and again share.
I'll stop and share it again. Okay.
Can you try moving it with the up and down arrows on the?
Yeah, but it's not happening.
So
Okay.
sometimes it happens, sir, when we share this PPT slides.
No, it's not happening.
Maybe we don't.
1 minute. I'll stop sharing and then do it.
Yes,
again.
stop share once and
Okay,
share again.
We will do it. नहीं उसमें उसमें डाउनलोड करके
Now it has come?
Yes, you can see now.
No, but it's not changing. It's not changing again. It's not changing. I think you run it. You run it.
Yeah, we will do it.
I'll stop sharing so that you can run.
Yes.
Oh, there is no button for a.
Yeah, we are playing your presentation now. So just tell me when to move to the next. I'll do.
What has really gone wrong? I don't know. Now that the stop sharing button has also gone. How do I stop it?
No, but we are sharing. Are you able to
Okay,
see?
you are sharing. Then I'll just
Yes.
bring it
Yeah,
down.
we have started sharing.
Okay, fine. So right now it's a model case sheet that you've done. Just go to a slide previous to this. No, the previous to that. Yeah, okay. Yeah, so next slide. So basically this entire presentation is into two pieces. The one is how you actually record your documentation as and when the patient approaches you first time. So the next, please. Next slide. So it's a model case sheet which I thought. So it will be, it will have a first your name on that first day paper. Next, please. So your qualifications, your address, next. Then the name of the patient here. So age, sex, height of the patient, BMI of the patient, chief complaint. So that will be probably in a case of lap chole will be a pain in right hypochondrium, vomiting, maybe occasionally no fever. Next, please. History of similar complaints in the past. Then whether the patient had a history of jaundice, then any comorbidities like diabetes, hypertension, ischemic heart disease, cerebrovascular accident. Next, please. Past history of any surgery if it is done. History of blood transfusion if it is given. Family history. This is all in record which we normally do it, but I have just tried to address all the issues. So addictions if at all he has something. Next, please. Present medication, if he's a diabetic, then what medicine? Is he on any blood thinner? So that should be separately mentioned, yes or no. And any history of drug allergy. Next, please. And then on every page, you must take a patient signature. Right. So on every page, there is a patient signature which is taken in this consent. Next, please. Then a general examination, which you normally do a build, temperature, pulse, respiration, blood pressure, pyloricterus, edema, lymphadenopathy. Next, please. The gross examination of respiratory, cardiovascular, and neurological system per abdomen. We draw this diagram and then we, next, please. So we draw that the area of tenderness or whether there is any guarding or no guarding. PR here will not be any relevant. So you can write down not relevant. Clinical impression then is probably a gallbladder pathology. We have not done investigation, but this patient has so many comorbidities. So that has to be mentioned as a clinical diagnosis. Then the investigations are done. So these are routine things like hemoglobin, WBC, platelets, ESR, blood sugar, fasting post-lunch. So this patient was diabetic and he was HbA1c was high, creatinine, serum electrolytes. Next, please. The HB, all the triple viral markers, the LFT, the PTINR, which is important, serum amylase, lipase, just to rule out. So in all these patients for pancreatitis, X-ray chest, ECG, and a 2D echo because most of them will be elderly. And if any other comorbidity, then specific investigation. The ultrasound will be the gallbladder, especially we write little bit in detail. There was a single stone impacted, wall thickening, fluid around the gallbladder, then common bile duct, pancreas, and any relevant findings. So this small must be there in our paper beside the sonography report. MRCP only if it is indicated like patient had a deranged LFT, then you would go for MRCP. Next, please. CT abdomen only when you are suspecting something more or you are not clear in your diagnosis, but not be a routine, but it should be mentioned that done, not done. Next, please. Then the diagnosis. So here it is a chronic cholecystitis, cholelithiasis with uncontrolled diabetes, hypertension. And then you write down your plan. The plan is laparoscopic cholecystectomy. Preoperatively, patient need to have a control of diabetes. Therefore, you refer to a diabetologist. Next, please. Reference to a cardiologist for fitness because he had an ischemic heart disease and hypertension, and stoppage of clopidogrel 5 days before scheduled surgery after consultation with cardiologist. If he thinks that patient should be on low molecular weight heparin during that time, and this is the barcode which you can right now take a click on of this thing. So this entire model sheet will be with you. Yeah, next, please. So this is consent for. So now we'll go to the model informed consent. So again, the consent form will be having a title of your hospital, the date, the consent for what? So it is laparoscopic SOS open cholecystectomy under suitable anesthesia. So that's how we write down the next. The patient's name, age, gender, a UHID number of your this thing, IPD number, consultant in charge is your name. Next, please. And the diagnosis. So this is the first part of the comment. The surgery proposed is laparoscopic SOS open cholecystectomy. So that's the surgery that is proposed. Next, please. So here it starts like this, that I, Gauri Shankar Jatasankar Maurya, and my relative have been explained the detail about my condition, that is the presence of gallstone and its associated disease, sequelae, namely cholecystitis with cholelithiasis. We have been explained that in many cases the stones may not cause any symptoms or may lead to mild pain or discomfort due to irritation, inflammation, or a swelling. Presence of gallstone can put a person at risk of having symptoms of varying severity, and such patients, whether symptomatic or asymptomatic, have a potential of developing various complications like infections, sepsis, jaundice, chronicity with adhesion, pancreatitis, and cancer. Jaundice can be due to inflammatory process or the stone sludge causing blockage of the bile flow and may require other procedures like ERCP. In these cases, there can be severe pain and sometimes it may cause a life-threatening infection like sepsis. Next, please. We have been explained that cholecystectomy, that is surgical removal of the gallbladder, is an internationally accepted treatment for clinical conditions arising out of stones in the gallbladder. We have been explained that patients with comorbidities like diabetes, coronary artery disease, on a blood thinners, chronic airway disease, obesity, etc., tend to have a poorer outcome and more complication as compared to those without such comorbidities. We have been explained pros and cons of various options of wait and watch instead of surgery. However, there is no other alternative treatment to surgery available for symptomatic gallstones, and not getting treatment may put the patient at risk of having jaundice, pancreatitis, cholangitis, or carcinoma of the gallbladder. We have been explained that the procedure may be performed by different techniques based on patient's medical condition, disease process, and available expertise and infrastructure of the procedure, likely to give an optimum outcome has been proposed. We have been explained that procedure, that is cholecystectomy, can be done by minimal access technique or by a traditional open method. In the open method, a big incision is being made in the abdomen, and in laparoscopic method, the procedure is done with a few cuts in the abdomen 5 millimeter to 1 centimeter in size, and carbon dioxide gas is introduced into the abdomen to distend and facilitate safe insertion of various instruments, including camera. Though through indirect vision of magnified structures, the procedure is performed step by step. On completion of the procedure, the residual gas is removed before removing the camera. The trocar needle injury while insertion is a rare complication which may cause torrential bleeding or intestinal injury. We have been explained in detail about the procedure of cholecystectomy, that is removal of gallbladder. During cholecystectomy, the gallbladder is dissected free from its attachment and surrounding structures. The cystic blood vessels and cystic duct are clipped with a metal clip, ligated or sealed, and divided using appropriate instrumentation, and the gallbladder is then removed. I have been explained that during surgery, the intraoperative condition may necessitate conversion of laparoscopic surgery to open procedure, or leaving behind a small cuff of gallbladder, or to do a drainage of the gallbladder in case of empyema, gangrene, perforation of the gallbladder, or even only leave a drain in the area around the gallbladder, deviate from the contemplated procedure, or even abandon the procedure in the best interest of the patient. I have been explained that though the procedure is largely safe, however, it is not always 100%. Though minimal, there is a small possibility of associated risk and consequences. In a very small percentage of patients, complication may occur, which could be the following, but not limited to. So then we have enumerated all the possible complications that we thought of. Bleeding, which could be minimal and may not need any further procedure. But in a small fraction of cases, there could be a major bleeding which may arise from a major aberrant vessel or the gallbladder or its surrounding structures. In some of these cases, it may need transfusion of blood or blood products, or a re-exploration, or may even be life-threatening. In few cases, the gallbladder may be densely stuck to the surrounding structures and necessitate conversion from one technique to another, or may need a longer time to complete the procedure, and even may cause inadvertent injury to some of the vital structures like biliary ducts, solid hollow viscera, or a blood vessel. Leakage of bile from the liver or a bile ducts, which may necessitate additional procedures or a long-term placement of drains in the abdomen, or a referral to some other center. Leakage of intestinal hollow viscous content, which may be noted immediately or later. It may necessitate additional procedures or even bringing out a part of the intestine in uncommon circumstances, or re-exploration if detected during post-operative period. Infection, which could be minor, limited to wound, or even causing a wound breakdown in some cases. In a small fraction of cases, there can be severe infection, sepsis, which may even be potentially life-threatening. It may even need an additional procedures or intervention or escalation of medicines. Unpleasant disfiguring scar or a scar site hernia in a small number of cases. In some cases, there may not be complete resolution of symptoms of indigestion or a pain. Next, there is a small possibility of incomplete stone clearance, as small stones or a sludge may be difficult to visualize, or sometimes may slip into the bile ducts. In certain cases, there may even be jaundice or a pancreatic swelling post-procedure, which may necessitate further investigation or interventions. Few cases may need a urinary catheterization, which may be associated with its own specific risk, like trauma, infection to the urinary system. In a small number of cases, there is a possibility of reaction to medication, which may be mild or life-threatening and cannot be predicted. Some patients may develop clotting of the blood in their blood vessels, which may be mild, transient, or uncommonly life-threatening. Some of these may necessitate stay in ICU or a prolonged stay in the hospital, or a long duration of tube feeding. Some of these may be more finance or resource intensive than the others, and though very rare, mortality can be a possibility. The additional factors for comorbidity, you write down any that is related to what comorbidity. So like a diabetic, you write down what can go wrong. The diabetes may haywire, or that could be an associated with diabetes, other complications. So that you can add it up accordingly. Next, please. These issues, other possible conditions and consequences have been discussed in detail with me and my relative in the language that we understand. Now here I would say that there was a little dispute amongst us that Dr. Suresh Deshpande kept on saying that this written consents have no validity because the patient may say that I don't understand English. Now, if you have taken rest of the places, his signature and his written in English, there is one way of saying that yes, that he actually knows it and he has been understood. But He said, what you should do is you should take a video consent and then store all these consents for a lifetime, which all of us thought that it is probably too much to do it. At the, like, I may have done 20,000 procedures. Where will I keep those consent and how will I trace them when I want to? So therefore, I think what we do is that we read out in front of them. We should read out this entire consent in front of he and relative, take the signature on each of these page, and that I think should be adequate. In fact, we had Dr. Suresh Vasishtha went, and this consent was ultimately sort of endorsed by a Supreme Court judge. And he said that this is a more than foolproof method and we will be able to bail you out if there is a problem. So with that, we thought that this validity of this consent remains even if it is written. But if possible, yes, you can take. Or then ultimately, some people said that what you do is that you read out this consent in front of them, and then you just, that small part you record it saying that I have been explained these 4 pages of consent. I agree to that the patient should say in his own language, and that much part is recorded so that he cannot completely say that I was not aware of this thing and I was made to sign without knowing what it is. I have understood in detail of our satisfaction, all our concerns have been addressed by the surgeon and his team. We have been given the opportunity to ask questions, including tentative estimate of expenses, and our queries have been answered to my and our satisfaction. We have understood the contents of this consent. Its contents have been read over to me. Next. We do understand that medical science is an evolving science and the human body is a very complex and individual anatomy and systems vary and differ from one person to other. At times, unexpected, unanticipated, unforeseen, undescribed events, complications, situations can occur, which may be beyond the control of doctors, though they do their best efforts to preserve the life, organ, and health of a human beings. After being satisfied with the pre-procedure counseling and the explanation, we have no further queries and hereby consent for surgery with free will. We, with a free will without any duress, give consent for proposed procedure, that is laparoscopic cholecystectomy or its modification as deemed necessary by the operating surgeon or a surgical team. I also give a consent for pre-operative, intraoperative, post-operative photography of the procedure in which my identity will not be revealed. I, with a free will, allow these photos to be used for a patient education, surgical education, or academic use. On every page of consent, the patient must sign with the date. And on last page of the consent, the signature of the patient, the signature of the relative, and relation with the patient. And then the consult and explained by so-and-so doctor, designation, date, and time. So this is how, and this is the barcode which you can scan it. So this consent will be in a PDF form. You can convert it. If you want to make some changes, you can convert it into a Word file and make the changes. So thank you so much. Those of you could not do a barcode, you can actually write to me. I can send you a PDF copy of this.
All the participants, please make a note of Dr. Punjani's email address in case you want some more information from him. Thank you. Thank you so much, Dr. Punjani. I think it was very detailed. So maybe I will start the discussion because I've noted down a few points. So some of the points I will re-emphasize because they need reiteration, and some questions I will ask you. See, he mentioned that in every case, MRCP and CT scan not done has to be documented, and preferably with the reason, because suppose after lap chole patient develops jaundice or pancreatitis and a CT stone, he or she will come back and say, why did you not do an MRCP before? So if you have documented that there was no indication to do an MRCP because LFT was normal, ultrasound did not show any IHBRD, you will be safe. And same way, if you find an incidental gallbladder cancer, the patient may come back and say, if you had done a CT scan pre-operatively, maybe you could have detected it. But then if you have documented that there was no indication to do a CT scan, you will be safe. So not doing something also, and the reason for not doing it must be documented. One question, Dr. Punjani, I want to ask. So, I understand that in every consent form, it is written laparoscopic SOS open cholecystectomy.
Yes.
So that's very important.
Yes. So it is
Yes.
laparoscopic SOS open cholecystectomy. Plus in that, what we have done is that we have sort of possibility of every sort of things which can, I may do a partial excision of the gallbladder. I may leave behind a stump purposely for the benefit of the patient, or I may leave behind a stone which may slip. So, we have tried to sort of cover almost everything that can go wrong in a lap chole.
Yeah, I saw that
And
you
in fact,
mentioned sub. Please carry
it
on.
was an Indo-SARC, IAGS SARC webinar. So even the people from Bangladesh and the other neighboring countries were also there. And in fact, then what three of them did is they actually brought actual cases that were happened in Indian court on three different complications of lap chole. So one was on, of course, bile duct injury. The one was on, I think, the intestinal injury, colonic injury, and third one was on bleeding or something. In all three, actually, the doctors have won the case. So purposely, they took it so that people's morals are not disturbed. People may say that, oh my God, let's stop doing lap chole. But at the same time, there is a possibility. So there are more than 1,200 cases have happened in India against a doctor. So I think it's very important that at least we are not caught in this in a stupid way by, in this documentation and a legal aspect of it. And I think we will take it forward. I'll talk to our president, and if IAGS can endorse it, then I think probably this can then become a sort of a legal document for all of us to follow in the practice.
Yeah, I saw that you covered the options of subtotal cholecystectomy, even abandoning the procedure in case of difficulty. So all this is very, very important. Another important point which participants you must have noticed is that everywhere it is written I/my relatives. That is very important, because suppose unfortunately the patient dies, then the relatives may say that we were never told, we never consented, because then the patient is not there. So both mentioning both is very, very important. Having signatures of both is very, very important. And of course, he has gone on to the details of CO2 and clip, because as we all know, there has been a case where there was a clip migration. And if it is mentioned that a metal clip will be used, then probably that will be a safety against that. One more question I want to ask, that do we need to mention the approximate or the range of percentage of complications?
So actually, because again, this may vary, even though we quote the literature also may vary time to time. So the problem is, what they said is that you just write down few percentage, and, you make it sound that these are not common, but it can happen. So we have not put any percentages for that matter. But yes, we can do that if you have an authentic figure saying that, but on so-and-so date, when we took a consent, the incidence of, say, bile duct injury was so many percentage, say 0.5% or whatever. So we can do that, but I think instead of just writing it vaguely, that's important, because, then you can always escape. You commit it to there, they may tell you.
Yeah, I think if we take it further together with IAGS, with AMASI and CELSI, maybe we will form a small consensus group which can say that which all complications need to be mentioned in what order, and whether we need to mention a range of complications, because that will have the consensus of all the experts. So we will probably keep that point in mind. And I will immediately after this, I'm going to make a request to the office bearers of all the three associations, if they can make a consensus group with representatives from all the three societies, and we can start working on this. The last point is about video consent. So I have with me my younger faculty colleague, Dr. Shaswat Sareen. He is our HPB and liver transplant surgeon. And obviously the consent process for liver transplant is also very detailed. And as a routine, we are doing a video consent. So I like him to say a few words about the consent counseling and consent process for transplant. Shaswat.
Good morning, sir. For transplantation, good morning, sir. Morning, Dr. Punjani. So for transplant, because of the number of parties and the number of legalities involved, most centers across India would choose to document almost every part of the consent procedure on video. It serves a couple of purposes apart from just the surgical bit. It also establishes the relationship between the donor and the recipient, which is important during transplant. What I found most interesting about your talk was the absolute detail, in-depth detail that we went into in each of those steps for the surgery. Unfortunately, for transplant, we are unable to do that. We ideally, if we were to go, ideally that's what we should do, but we're unable to go into such depth of each part of the surgical procedure. But what we do try to establish during that consent meeting is at least give the both the donor and the recipient an approximate inkling or an idea of what a normal post-operative course is and what are the variations to that post-operative course. Because with transplant, there will be maybe at least a 30 to 40% incidence of morbidity one way or the other. So that's what we try. A normal transplant meeting would go on for about, a consent would go on for about 20 minutes to half an hour, in which we'd explain the donor and the recipient the risks separately, especially because there is a tangible risk of a donor complication or a mortality attached as well. For them, some centers, what they do is actually they allow the donors and the recipients to have a copy of the consent form one day earlier, because it's a big form. So it probably you can't expect that any person goes through that entire form in 20 minutes, the information booklet. So some centers actually give it a day earlier so that the patients can go through it at length and at leisure. It will take probably an hour to go through the entire literature that we give the patients. And then when they come back to the consent meet the next day, you go over the salient points. And in case they have any questions or queries, they may then be answered. So that's my 2 cents.
Anand, if you are there, you want to make any comment?
Yes, sir.
As I mentioned, Anand is my faculty colleague again in HPB and transplant, and he has been running show of Jaipur surgical tutorial for last 2.5 years. Yes, Anand.
The basic purpose of today's guest lecture was mainly for the benefit of all the surgical residents or surgical specialists. All as we know, we are doing the lab poly by day in a visual numbers. So we should have a consensus on this informed consent, and we should have a single format of this informed consent for lab poly, like we are doing in the liver transplant. So as you will take this for further, and we can have a single format for all our country with the help of Punjani sir. I heard his lecture, and I found it will be useful for us and for all of you, as you have a more interest in colleagues cholecystectomy. So I introduce this topic.
Rajen, you want to make any comment? Dr. Rajen Desai is a senior GI surgeon.
No,
From
no,
SGGI.
I'm quite there.
Any of the participants want to ask anything from Dr. Punjani? Any clarifications? Any queries? Dr. France, Dr. Yakub, you want to say anything? Anything which is different in your place from what we have discussed? So if not, Dr. Ramesh, I would request that if you can send me the PDF version, so we can start working on it. I will write to IAGES and other societies.
Drop a mail to me, I'll immediately send you.
Yeah, I will send you my email address, and then maybe we can form a small group which can start working on it, and then we can get it endorsed by all the 3 associations, and then on a larger scale, we can request even the ASI to endorse it. Because I feel that if there is a uniform standard consent form, then that fear, because whenever I talk about medico-legal issues in lab poly and I tell the surgeons, general surgeons, that you should mention all these things in the counseling and consent, their fear is that if we say all this, the patient will run away. But if it is a uniform consent form, so whether the patient goes to you, me, or Shashwat or Anand, he faces the same consent form, then this fear will disappear. Then the patient will not or cannot run away. So that is my intent, that it should be a uniform consent form which every surgeon in the country should be using.
Correct. So wherever you go, he has to sign the same consent.
Thank you very much, Dr. Punjani, for your time and for this very nice presentation. And I hope that we will be able to do something together on this along with the societies. Thank you very much.
Thank you, sir.
Anand, shall we close?
Yes, sir. We can, sir.
Okay. Thank you. Thank you.
Thank you. Okay, sir. Thank you, sir.